Hello, hello, everyone. Welcome to this edition of Ask the Expert. So we are here on Wednesday, April 19th. It is 9 on my part of the world. Steve, you're in the East Coast, so it's noon, right?
It is noon in New York.
Yes, very different New York time. And I know we have people from all over the world. So one of the things that I'm hoping people will do is go ahead and tell us where you're from. So put in the chat, just announce like, hey, my name is this, or if you don't want to say your name, where you're from, and what brings you here. Like, who are you supporting? Are you supporting yourself? Do you have a loved one? Do you have a friend, a cousin, a family member, etc.? So I'm really excited about Ask the Experts today. So before I announce the guest and everything, I just want to say real quick that there's a couple quick announcements I want to make. So the live stream is educational, is not intended to replace therapy. So for the treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online research directory at iocdf.org//find-help to locate a trained clinician near you. So we're here to kind of educate you, give you some direction, give you some tips, really get you on your way to getting better. But definitely making sure that if you need more advanced care, that you find a clinician that can work with you. We're also not a crisis hotline. So if you're in a crisis or you're feeling suicidal or unsafe, please go to your local emergency room or call 911 or 988 Suicide and Crisis Lifeline by dialing 988 or going to www.988lifeline.org. We want to create a safe space and be kind and respectful to everyone. So at the end of the day, we're all here to support one another. And a note that this is being broadcast on several social media platforms and is being recorded. All right, well, today's Ask the Expert is special. So first of all, Liz isn't here. She's taking care of something with her daughter. So she sends her love. She hates missing these. We all both hate missing these. But this is an Ask the Expert. So my name's Chris Tronson. I'm a licensed therapist here in Orange County, California. I've been treating OCD at some capacity since 2009, and I have OCD myself. I'm one of the IOCDF's lead advocates as well as a board member, and just here to kind of answer your questions both clinically, sometimes throw in some lived experience. And I'm super excited about our guest because we get a lot of questions around medication consistently, and I feel bad because if you're not familiar, licensed therapists cannot offer medication direction. We can kind of give you some feedback or guide you in the right direction, but we can't give you specifics. So luckily, we have someone who can. So our guest today is Dr. Steve Poskar. He's probably going to tell me I'm pronouncing his name wrong, but we'll see. Poskar, I think it is, but I add a little Poskar. I don't know. Just make it sound fancy, kind of like Target. He's one of the nation's leading experts on the treatment of OCD and related disorders. He's a member of the Scientific and Clinical Advisory Board of the International OCD Foundation. He also serves on the faculty of the IOCDF BTTI, that's the Behavioral Therapy Training Institute, where a lot of really good therapists have been trained. Dr. Poskar co-founded OCD New York, a charity whose mission is to help those affected by OCD and related disorders to live full and productive lives. Dr. Poskar is one of the few clinicians in the country with expertise in using both medication and CBT to treat OCD and related disorders. Patients are commonly referred to Dr. Poskar by their individual therapist so that he may treat them with medication. In these cases, Dr. Poskar works closely with each patient's therapist because he views this collaborative approach to be essential for the provision of the best possible care. Dr. Poskar is medically licensed in New York and Florida. So welcome, Steve. How are we feeling today?
I'm feeling good. Thank you so much for having me again. I am excited to be invited back. And, hopefully, again, we can kind of, answer people's questions on medicine and, because it's really hard for a lot of patients out there to kind of access, especially psychiatrists that have real expertise kind of in OCD and related disorders.
Yeah, so we're super excited to have you. We're going to jump into those questions. So I'll take some live ones first, and then we have a bunch of pre-submitted. So we have a question at 12:30, or no, 11:30 your time, 8, 9, 10, yeah, I'm so bad at time zones. 11:30 your time, Amanda. So it's from Badhan on YouTube, asked, I've been taking an SSRI-based medicine, 50 milligrams, 2 times per day for 6 years. Consumption of SSRI for such a long period, would it hamper my health or cause any severe issues in my body? So we get this question a lot. So it sounds like they're on an SSRI 50 milligrams twice a day for 6 years. Is taking an SSRI that period of time, has there been anything that's showing that it may cause any severe issues to the body?
So a few things, one, just as far as, being on an SSRI. So, there are a number of SSRIs, and, the dosing for each of them is different. So 50 milligrams of one SSRI is not necessarily going to be the equivalent of 50 milligrams of another. I have a feeling, my guess is, based on the 50 milligrams, it's probably sertraline, which is also called Zoloft, is my guess. But again, as far as the SSRIs go, they're really safe medicines. And I know sometimes people might think, oh, well, he probably says that they're all safe because this is what he does. But there are a number of medicines we use in psychiatry that have kind of risks that we have to watch out for. Medicines that we use for certain mood disorders like bipolar disorder can affect the kidneys and can affect the liver. Other medicines we use can affect the neurological system as far as movement goes. But SSRIs are really, really safe medicines. And so as far as we know, there doesn't appear to be any long-term damage to the body. There doesn't seem to be any liver problems, kidney problems, cardiac issues. And so these are really safe medicines. And again, one of the things I always try to emphasize is, one of the things that these medicines do is kind of lower kind of the body's kind of stress response in general. And we know that kind of cortisol and that stress response can damage the body long term. And so if anything, I think they're probably protective long term of one's health.
I like that you say that. There's a really good book by a Stanford neurologist. His name is I think it's Dr. Polsky is his name, or Dr. Sapolsky, or I'm butchering his name. But he wrote a book called Why Zebras Don't Get Ulcers. It's a really popular book on neuroscience, and it talks about what you were just saying, that unfortunately when people have OCD, anxiety disorders, if it goes for a very long time in the body untreated, that cortisol consistently, he uses the example, it's kind of like leaving a bunch of like 50 kindergartners in a room on a rainy day and the teacher leaves for an hour. Like, what do you think is going to happen to the room when you come back? It's going to be destroyed. And prolonged high cortisol levels over time can be very damaging. So I like that you talked about that, because I think sometimes people don't think of that as a risk, but think of the medication as a risk. And it's our bodies are not meant to be that anxious.
Great point, right? That sometimes people say, sometimes I think people look and they judge medicine and they say, well, is it better to be on medicine or off medicine? And if you have no problems at all, then yes, I'd rather you not be on medicine. But that's not the equation, right? The equation is kind of sometimes medicine versus unchecked disease. And when you have OCD or any psychiatric disorder, that takes a toll on the body. And so, again, it's that being untreated, like you said, is also a risk. And so we're always kind of weighing those. And again, SSRIs, they're really well tolerated. And it is why we use them so often, is that they can help a lot, but the downside is also minimal. Again, people can get some side effects with SSRIs, but most of those are kind of things that are only there when you're taking the SSRI, and usually are kind of well tolerated. So, again, just back to that, initial question, these seem to be safe drugs. And again, we've had the SSRIs, drugs like Prozac have now been out since, trying to think, 1980. So, we're looking at kind of up to 40 years of experience with these meds. Sometimes drugs are newer. We can't really say long-term because they haven't been around for long enough. But SSRIs now have been around for about, 40 or more years. And again, so we have people that have been on them for that long. And again, they seem to be safe medicines for people to take long-term.
Well said. So we got another question. This comes right about at noon Eastern time from Natalia. She says, how long should a 24-year-old female stay on Effexor 300 milligrams after the signs of full recovery from OCD symptoms? Plus, they just started 25 milligrams of clomipramine. They're afraid of side effects.
Okay. So one thing I'm gonna take a step back for, and I think that we should both say is kind of, we can't give exact advice for particular people's medicines and what they're taking and things like that. So, we're going to try to talk more generally today. But just looking at the question, so, the person is on Effexor 300 milligrams. So first, maybe we should just tackle that. So Effexor is also called venlafaxine. And venlafaxine is what's called an SNRI. And so the SSRIs, which are the standard treatment for OCD at high doses, are selective serotonin reuptake inhibitors. The SNRI stands for serotonin and noradrenergic reuptake inhibitor. So it actually increases not only serotonin in the synapse, but also the neurotransmitter norepinephrine. Effexor seems to be predominantly a serotonin reuptake inhibitor. And so it does appear to work for OCD, but the data is not the same. And so typically it's not something we start people on right away for OCD, but sometimes it's a drug we go to when an initial or a second SSRI doesn't work. And usually, again, they're going to have to be at higher doses to work for OCD. When we use SSRIs, the difference that is when we use them for depression or an anxiety disorder versus when we use them for OCD is that the doses we need tend to be higher. And so, when we're using an SSRI or an SNRI, and people recover from OCD symptoms, and what recovery means is difficult to say. Typically, when we talk about a response to an SSRI or an SNRI, it's typically people having an improvement in, a 50% or so improvement in symptomatology. And so, most people don't fully, recover, as in, we don't usually have people that go into complete remission where they don't have OCD symptoms, right? That's, when we're treating depression, we can often see people completely remit and they no longer have any symptoms of depression. Doesn't really happen in OCD, right? We're really looking for an improvement. And so, but if somebody's doing well on medicine for OCD, whether they're in therapy or not also in therapy, sometimes we try to see if they can come off of a medication. And, for a lot of people, when we take them off medicine, they just don't do as well. And so I think it's one of those things that if people want to get off medicine, it's something we try. But then when we do it really, really slowly. And so, because you don't want to see someone who's doing well and then stop their medicine and then have them relapse, and now we're in a really bad place. So usually if somebody's on a medicine, I'm usually going to make a drop 10% in their dosage and then give them a couple of months and say, are they still doing okay? If they're still doing okay, I might drop it by another 10%. And that way we see, because sometimes what we see is we can get somebody on a little bit of a lower dosage where maybe they have less side effects. And then when we try to lower it more, they don't feel so well. And then we know, okay, we didn't get you off the medicine, but we got you to a lower dose. But again, there's no particular time period. I would usually say if somebody's doing well, I'd like to see somebody doing well for at least a year before I would ever try to lower somebody. I think one of the things we know is that the longer the brain is doing well, the kind of better it is to stay well. And so, for me, I think some people, they start doing well and they want to go off medicine that day. And to me, I really want to see somebody doing well and getting, because remember, like when we're doing therapy for OCD and we're getting OCD better, we're changing your circuits and we're getting your brain into new habits. The longer you're in a new habit, the easier it is to kind of maintain that habit. And so to me, again, I'd like people to do well for at least a year before I'd even consider whether that we want to think about lowering or stopping their medicine. But again, if you look at the data, a lot of people who go off medicine, unfortunately, do kind of relapse in symptoms. And so for a lot of people, and I think this goes back to our last question about safety, a lot of people are on these medicines for life for OCD because they're helpful and they're safe.
Yeah, no,
I would say quickly, I'm sorry.
Yeah.
And clomipramine, just so people know, is what's called a tricyclic antidepressant. Clomipramine was the first drug we ever had for OCD. And clomipramine is a tricyclic, and most tricyclics affect primarily norepinephrine. And clomipramine was the first one that really affected serotonin. And so it is a serotonin reuptake inhibitor, though it's not a SSRI that's selective. And sometimes we use that for OCD, and sometimes we use that as an adjunct. In this case, they're using a small amount of clomipramine, and again, not exactly sure why. It's a little confusing given the person saying they are kind of getting recovered. But again, we could probably talk about that more with a later question.
Yeah, no, I was just going to say in my own case on medication, that's what my psychiatrist did with me. It was like after about a year, like a solid year of not really showing symptoms, I'd finished treatment. And I would say about 2 years after treatment, I was at a point where pretty much like my family, my friends, I was working, I was back into life. My family and friends were like, wow, like you're a completely different human. We rarely see any symptomology. And I would go days, weeks, months without any kind of flare up. And so after about a year of just not really showing signs or symptoms, and every time I'd meet my psychiatrist, Dr. Jamie Fusner, we'd have nothing to talk about. And he'd just kind of be like, so, like, shoot, we still have 25 more minutes. So that's when Dr. Fusner, I'll never forget, one of the things he was talking about is like, what are some things that you're doing for your wellness? So we talked about exercise and working and school and friends and stuff. And after about a year, we started tapering, like you said, very slowly. And because I never saw any flare-ups during that taper, I stayed off, and I was very fortunate that none of my symptoms came back. Just a quick clarifying, when you were talking about, obviously medication for depression, the medication alone can really help lift all the symptoms. With OCD, it's only about 50%. That's why, just for clarification, if people are new, that's why, obviously Dr. Poskar, because he practices that as well. That's why we're so passionate about the combination of medication and CBT, specifically ERP, is because medication alone, I have met people that don't want to do the treatment, but will take medication. And like Dr. Poskar says, they'll show like 50-60% like reduction in symptoms, but it's really the people that do the combination, probably like the person who asked the question, that are in that recovery mode where day to day, they're not making choices based out of the OCD.
And I think that's where, again, like, you're always looking, the hope is that, again, I think everybody with OCD should do therapy because it's the main treatment. And if you don't learn how to respond to your symptoms, you're just going to reinforce them, right? That's the problem, right? Is not knowing how to do the therapy is not just that the therapy can't help you if you don't do it, but actually it kind of is destructive, right? Because when you're doing compulsions, you're reinforcing your OCD, right? You make it worse. And so it's really important that people do the therapy. And I think what happens sometimes is we start people on medicine and on therapy, and then they do well. And then the question is, can they continue to do well with just the therapy alone, right? And can that kind of continue kind of their brain doing what we want it to do without the medicine any longer? And again, it's always hard to know because we kind of got them better often using both. And then the question is, can they stay better? And again, in some cases they can. But I often tell people, if you don't want to be on medicine, the best chance you have is doing and hitting the therapy as hard as you can, right? And really, really, because again, there are plenty of people, we should say, that do get better, right, from OCD on therapy alone. And there are plenty of people, that I treat that I've never used medicine with, and therapy alone is enough for them. A lot of people, and I'd say most people with significant OCD, really do best on both. But there are rarely anybody that does well on medicine alone. It's just not enough of a treatment. And again, some people refuse to do therapy, and at least we can give them some relief with medicine. But again, it's usually, again, a symptom reduction, not, there are not the number of people that, I've ever heard of that say, started on medicine, I just don't have any OCD anymore. I wish that were the case, but unfortunately, those are few and far between.
Yeah, I always think for me, when I took the medication, I noticed that my thoughts were less intense, less frequent, less loud, and it was a lot easier to not give into them. I did my first 6 months of treatment without medicine, and then, finally gave into medicine. And for me, it was just like, oh, okay, this is why people push, the combination with medication, because I started noticing like I would get quicker relief from the exposures that I did. When I changed the way that I addressed my thoughts and my feelings, it started to stick. So, I'm always a proponent of both.
And I think that's why one of the things I always, when I talk to patients, one of the things I talk about with medicine is kind of my idea. I often think of it as I'm turning down the volume, right? That the OCD is sometimes so loud for people that they can't even imagine doing the therapy or really engage in it. And a lot of what I'm doing with medicine is lowering the symptoms down so they can really now engage in therapy to the maximal degree. And that's a big thing that again, I think of medicine as really bringing down the volume of the OCD.
Well said. Amanda, we have another question at noon from Bastian on YouTube. It says, I have heard that some SSRIs can actually make your anxiety worse. Is this true? There's a second part to the question. They say also, do you have to take them forever, even if you start to feel better? So I think you answered that. If you want to add more, you can. But for that first part, can SSRIs make somebody's anxiety worse?
Sure. So it's a great question. So SSRIs, one of the things that happens is we know that SSRIs, when we give them, they don't work right away, right? You don't take them and feel better in a day. And that's because, at the beginning, what they're doing is causing an increase of serotonin in the synapse. And then that affects different receptors downstream, which affects different gene expression. And it's a whole process that takes a while. But the first thing that happens is it does kind of cause this initial increase in serotonin. And sometimes for some people, that can cause a little bit of anxiety at the very beginning. It's most common in people that also have panic disorder. Panic disorder patients are the most likely to get that phenomenon, where when you start them, they get a little increase in anxiety, but anybody can get it. And that's one of the reasons I always start medicine very slowly. And so, often that can be ameliorated by kind of starting the medicine at a very low dose and kind of increasing it slowly. And again, when people get that, it pretty much usually goes away for almost everybody. Occasionally, there are going to be some people that just, again, are very sensitive to medicine. But for the most part, that initial anxiety response, again, as those receptor changes start to happen, goes away pretty quickly.
Okay, well said. At 12:07 from Howard, do you have an opinion on ketamine treatment? And then the second part of the question is, there's the new glutamate study. I believe that's out of, it's going to slip my head. Biohaven. Maybe. It could be Biohaven. It might be a different one. But Howard at 12:07 says, do you have an opinion on ketamine treatment or the new glutamate study?
So a few things. So right now, there's been a bunch of different research going on. One of the real top people in this area is Dr. Caroline Rodriguez at Stanford. And she's done a lot of the research on ketamine and OCD. And as of now, there's just no convincing evidence as of now that ketamine is effective for OCD. And that doesn't mean that it's not. It just means that right now, we just don't have any evidence or data, does not show it yet. And so right now it's not something that we recommend to patients typically. And ketamine is, used for depression and often is a really good drug, it looks like, for people that don't respond to other medications. For depression, often respond to ketamine. And ketamine is a glutamatergic drug. It affects the glutamate system in the brain. And so, one of the things that people have looked at, so Dr. Christopher Pittenger at Yale is one of the top OCD researchers in the country. And he's really the leading expert on the glutamate system in OCD. And one of the theories is that people with OCD might have increased levels of glutamate. And that glutamate is what turns brain cells on. It's kind of the on switch. And that kind of overactivity in certain circuits with people with OCD might be caused by increased levels of glutamate. And so there are several different drugs that affect glutamate in different ways to lower glutamate. And one is a drug called Namenda, which blocks certain glutamate receptors. Another is a drug called Riluzole, which actually increases the ability of the kind of brain cells to suck kind of glutamate out of the synapse. And all of them have been used, and some have had some success in trials. And right now there's a current study going on, and it is a different molecule. It's a version kind of Riluzole, but it's kind of a metabolite. And they're looking at that currently in studies. I don't know where they are at right now, and I don't think we're at a place where we can say that it works or not. But I do think the studies, from my understanding, look pretty good. But again, we're just not there yet, I think, at a point to say that this is something that works. And Biohaven is continuing that study. And I think Dr. Pittenger is kind of the lead investigator in that. And again, we're hoping that then it looks like a drug that will work as an adjunct to kind of adding to an SSRI. And we're hoping.
Well said. We have a question at 12:08 from Moonchild on YouTube. It says, I'm afraid of taking medicine because of the side effects, so I've never tried. What should I do? So I think that's the biggest question I get also when clients are thinking about medication. So can you talk a little bit about the side effects? Are they permanent? And are there things people can do if they're on a medication and they're finding that the side effects are happening?
Sure. So I think one of the things we should bring up here is, I think it's important that patients all make that final decision, right? That it's always the patient's decision of whether they're going to take medicine or not. My job is to make sure that they're making an informed decision, right? And so one of the things I don't want is for people not to try taking medicine because they have fears that aren't really founded, right? So a lot of people are worried about side effects that the medicines we use don't actually even cause. So it's always important that people are aware of the pros and the cons and what the side effects are. And I think the first thing is really discussing with a psychiatrist, right, of what the medicines are and what the side effects are. So I think that's the most important thing you can do. The typical medicines for OCD are typically high dose SSRIs, and they're typically really well tolerated. If people are gonna have side effects that make them either quit being on the SSRIs or just having problems with them, the biggest ones people struggle with sometimes are sexual side effects. And in men and women, the most common sexual side effect is what's called anorgasmia, where it's the delayed orgasm phase. The second most common sexual side effect that SSRIs cause is low libido, so that's decreased interest in sex. Often these things are kind of mild for most people, and if they do have them, there are ways we can kind of treat them. Some people also worry about weight gain. Weight gain with SSRIs can happen. It's usually mild, usually in the kind of 3 to 7 pound range if it happens at all. Many people don't get it at all, but if they do, it's usually minimal, and often diet and exercise is enough. But there are ways that we can treat that. But again, as we talked about long-term, these drugs are really safe, and most people tolerate them very well.
Okay, thank you. 12:09 from Tariq. How about any other medication rather than drugs? So I guess that's I can look at it as two ways. We talked a lot about like SSRIs, SNRIs, clomipramine, et cetera. Are there any other kind of class of drugs that are helpful with OCD? And then the second question maybe, is there other medicine, maybe like, over the counter or a supplement or something that's been found helpful?
So, the only drugs that really are proven to work for OCD are the SSRIs, or SRIs, I should say, right? So just to clarify a little bit, so SRI would be serotonin reuptake inhibitor. And again, clomipramine, the original tricyclic that we used for OCD, is a serotonin reuptake inhibitor. And now the most common ones we use are the selective serotonin reuptake inhibitors. And so clomipramine and the SSRIs, and also sometimes using Effexor, which is an SNRI, but drugs that are SRIs really are the only things that are proven to work for OCD. Other than, that we have some data that when people don't respond or have an incomplete response to an SSRI, often using low doses of what are called neuroleptics or atypical antipsychotics or typical antipsychotics that block dopamine receptors, they can also work for about a third of people. So if you look at people that don't respond well enough to SSRIs alone, if you add a low dose of a neuroleptic, about a third of those people will respond to that. And that's really where our data is. Everything else, we've looked at a bunch of different supplements and things like that. I think the main one people hear about is called N-acetylcysteine. Some people know it as NAC or NAC. But really, the only good data for NAC is really on trichotillomania, and which is hair pulling. And there's some data on skin picking. The data for NAC and for OCD isn't persuasive. And so right now, there are no real over-the-counter treatments that really have proven that they work well for OCD, unfortunately.
Okay. Matt, so a lot of people said hi to us, and I feel bad not saying hi back. So I wanted to quickly say, everybody that said hi in the chat, I promise you're like my family now. So I wanted to say hi back. I don't want to be rude. 1210, we have from Matt B, who's a friend of the show, asked, can females take SSRI safely with pregnancy?
So this is a good question. And I think we should always start this by saying anybody that's going to think about taking any medicine while they're pregnant needs to talk about it with their OBGYN, right? And that's a really important thing. What it looks like, again, I think there were a lot of concerns early on with the SSRIs in pregnancy. As time has gone on, I think we realize that for most people, especially if they have significant illness, most people do best actually staying on their SSRI during pregnancy. There are definitely, different studies and there's some data that shows that there are some effects on pregnancy, possibly. But again, usually, even from my understanding of the data, even when they affect things like birth weight, it's usually still within normal limits, right? So if you can imagine that normal is between, I don't know, we were just going to give you a number between 0 and 10, and average is 5. And people might go down to 4 of something, and they're still in the normal range. It's just a little lower than maybe typical. But for the most part, again, it looks like SSRIs are safe in pregnancy for most people. There are certain ones like Paxil sometimes we avoid because there are certain concerns with certain heart issues. And so paroxetine is not one I use in pregnancy. But again, I think the other thing to really important here is OCD loves pregnancy, unfortunately, right? That OCD is something that really grabs onto pregnancy, right? If you can imagine being uncertain, do I feel the baby move? Do I not feel the baby move? The doctor said I can only lift things 10 pounds or less. Is this 10 pounds? Is it 9 pounds? Then even once the child, child is born, checking in on are they breathing or not. And so OCD can often worsen in pregnancy. And just like depression, sometimes you can have kind of a postpartum OCD spike. And so, one of the things we also have to weigh again is, while we'd always like people to not have to be on any medicine during pregnancy, the difference is not between being on or just being off medicine. It's being on medicine and having your OCD controlled, and being off medicine and having your OCD uncontrolled. And having uncontrolled OCD really can affect pregnancy. It can, obviously, it's increasing stress hormones. And that's not good for the fetus and the child either. And also, I want to make sure that the mother has the ability, especially then in postpartum, to bond with the child in the way that they want. And if their OCD is uncontrolled, it can really get in the way of that. So again, these are decisions that always should be made with your psychiatrist and your OB. And I always tell patients, I am always happy to speak with their OB so that we can kind of come to a consensus. But I can tell you in my experience, and I've been doing this for a long time now, I can't think of any OBs that I've talked to that have ever told my patients that they should get off their SSRIs if they need them. If and again, I think there are some people maybe that, don't need their SSRIs or could try. I always tell people, if you're going to try going off an SSRI because you're planning on getting pregnant, do not wait until you get pregnant to try that, right? And so if I have somebody and they are, and they've decided for them, they want to try doing their pregnancy without an SSRI, I want to try that 6 months before they get pregnant because I want to see how you do, right? Because if you're not doing well, then we know, okay, we maybe shouldn't try this during pregnancy. I think that time is not the time to be experimenting if you can avoid it.
We have a question from YouTube at 1210 from Amy. Is it normal for someone who's been on a high dose of prednisone long-term, 80 milligrams, not to return to a normal baseline of mood after tapering off of it?
Yeah, again, we should probably steer clear. So prednisone is not a drug that we use for anything in psychiatry. Prednisone is a steroid. And so prednisone is a steroid that we use for lots of disorders, right? Steroids are used regularly for diseases where there's inflammation in the body. And so, sometimes prednisone can affect people's mood. And usually, again, that usually when people stop steroid, their moods return to normal. But again, this is not a drug that we use for kind of OCD treatment or for any psychiatry treatment. It is a drug that we are aware of because sometimes we have patients on it and it can negatively impact their mood. And it's something that we watch. But typically when people go off of the steroid, their mood returns to normal.
I love the background because that's how I envision New York, is like constant noise. I love that. It's like, it's on brand. It's on brand.
That is New York for you.
Well said. So it's a little bit of a longer question, but I'll sum it up, and then Amanda, maybe you could put the part that starts with "so can Dr. Poskar." But Kayla on YouTube says that for many people, their OCD latches on to all the different side effects associated with SSRIs or medications. And then they learn, like most of us know, that the risks of what OCD latches onto is usually quite low or rare. So can Dr. Poskar provide some general psychoeducation about how to manage this OCD theme? So when OCD latches on to side effects that maybe haven't even happened yet without the involvement of a therapist. And how does the severity of OCD affect treatment approach when OCD fears are present? So how can someone sort of deal with their OCD latching on to side effects that maybe either makes them not want to go on medicine, or maybe they're on meds but are so anxious because they're ruminating consistently about it?
And this is, I'll tell you, this is a really good question, and it's actually one of the more complicated things about my job and my role, because part of my job is to educate patients on the side effects and things like that. But then knowing I'm treating OCD patients, right? Often they will start asking questions compulsively and researching, right? And then at some point, it's up to me to know, okay, I've already answered this question, so I've educated them. And now when they keep asking me, now I have to recognize that as a compulsion and not keep answering them and not have them keep researching. And so I think one important thing, for patients is, you want to definitely get informed, and you always want to know about side effects and everything. But then at that point, it's for you to kind of start to understand, do you kind of have the information, and now are you just not 100% certain you're clear on the information? And that is kind of where now we're getting into doing compulsions and really working on not looking up things on the internet, not kind of asking repeatedly or multiple people about the same side effect over and over again. And I think one thing for me that's always important is, for a lot of these people, I have to see them more frequently as their psychiatrist, because they do get nervous, and they get nervous about possible side effects. And one thing that we always have to be aware of, right, is people with OCD in general, right, are very sensitive to kind of subtle changes in their body and what they're feeling. And so it can get really hard at the beginning. What am I feeling? Is it a side effect? Am I even feeling what I'm feeling, or am I just imagining what I'm feeling? And so, it's really important. And this is why everybody should be working with an ERP therapist. And that when I'm doing medicine for somebody with OCD, I work really carefully, if they have a therapist, if I'm not the therapist on the case, with their therapist, so that we are both a team working on them being able to get and stay on their medicine. Because it can be really rough, especially at the beginning, because there's a lot of OCD that can surround it. And again, one of the problems with OCD, as we all know, is it's a disorder of certainty, right? And since we can never be 100% certain about anything, that includes medicine and side effects, and so it's one of those things where we really do have to realize when we're educating someone on medicine, and then when it's starting to get into, we're not educating them, we're actually feeding into their compulsive questions and kind of being able to show them what the difference is, and really make sure that we are educating without actually giving in and kind of helping them and kind of giving them reassurance, which is difficult. It's a difficult balance.
Yeah, and I don't know if this helps you, Kayla, but one of the things that helped me, because obviously I had OCD around the side effects, a lot of my OCD was around health. And one of the things that I did is I said, look, if a side effect comes up, then I'll address it with my psychiatrist and we'll create a plan. But I'm not going to invent a side effect, because my brain would get really good at fixating on things and being like, well, today I coughed more, or, did this happen or that happen? Or, oh, I think I gained a pound, ignoring the fact that it's the day after Thanksgiving, right? So it's sort of like, if something arises, then I'll deal with it, but I'm not going to prematurely start to try to fix things that haven't occurred yet.
And I think the thing I always try to remind everybody of, and I think maybe this is the most important thing, and I just thinking of it now, one of the things I always tell people is, as obvious as it might seem, it's not surgery, right? You're not doing something that once you do, it can't be undone. And so what I always tell people is, when we can always we're always doing a trial of medicine, right? We're always doing a trial where we're seeing how you respond, do you get benefit from it, and do you get side effects? If you get side effects that for you get to a level where they are unacceptable or we can't treat them in some way, we can always stop the medicine. And every side effect that we are aware of that people get on SSRIs goes away when we stop the medicine. And so that's one of the ways I get people who are afraid to try medicine to try it. No, it's a trial. You're not signing up for medicine for life. You're trying something and you'll see. Does it help? Does it hurt? What are the benefits? What are the downsides? And again, if you were getting things that you don't like or side effects, or you just don't want to be on medicine anymore, we can always stop it. And all SSRI side effects that we know of kind of typically go back and revert once you stop the medicine.
Well said. We have Melanie at 1212. It's a little bit of a longer question, so I'll read it, but then I'll repeat like the main part of the question. So they have a 16-year-old with severe OCD, and they were at Rogers. They're on both Prozac and Abilify, and that's helped them do ERP. The problem is the Abilify causes her to gain weight, even though she's active in things like show choir, cheer, and moving a lot, because her body metabolizes meds very rapidly. Her doctor just put her on metformin after a couple other meds that just did not work for her. Is this something that's recommended? So it sounds like the Prozac and Abilify combination really helping with ERP, but there's some weight gain from the Abilify. And so now they're on metformin after trying a couple other ones.
Sure. So a couple of things. So Abilify is aripiprazole, and it belongs to a class we discussed a little while ago called kind of neuroleptics. Or we could sometimes refer to them as atypical antipsychotics that Abilify is part of. And we know that at low doses that they can be helpful for OCD when we add them to an SSRI. Atypical antipsychotics can cause significant weight gain, much more than what we see with SSRIs. And in some people, it can be really significant. People can gain 30, 40 pounds. And so, the question is what do we do when people have weight gain? And I should just say that when people get weight gain, it's not usually just weight gain that we're concerned about with these drugs. Any of these kind of antipsychotics, especially the atypical antipsychotics, can cause what we call kind of metabolic syndrome. And that's not only weight gain, but it can be increased blood pressure, increased cholesterol and triglycerides, increased in kind of blood sugar levels, and pre-diabetes. And so we kind of worry about that whole package, and it's something we really want to look into. And that's why anytime you start somebody on one of those drugs, you have to get their blood sugar levels and their cholesterol levels before you start the medicine, 3 months after you start the medicine, and then at the year mark, and then every year after, because we want to make sure that they're not getting any of those metabolic issues. When people get them, there are a couple of different treatments that sometimes we use. One of them is metformin, and metformin is a drug that is typically used for diabetes. And it is a drug that kind of sensitizes the body more to blood sugar, and for people that are diabetic. But one of the things it often also does is cause weight loss for some people. And we know that for some people that are on atypical antipsychotics, metformin can help with weight loss. And it's one of the more common strategies used. And it's a fairly safe strategy. And so it is something that we try, and is often for a lot of people one of the first or second things they will try when they have kind of atypical antipsychotic, or really any kind of psychotropic induced weight gain. And so it is a common drug that we use.
Matt asked us at 1213, can you consume alcohol safely without major side effects while being on SSRIs?
So good question. So a couple of things. One is, alcohol in general we should talk about. And one thing that everybody needs to be aware of is alcohol is a depressant, right? And so if you use alcohol on a regular basis, so if I have somebody that comes in I've never seen before and they have depression and they tell me they drank kind of 4 or 5 times a week, 3 or 4 drinks a day, I don't know whether they have major depressive disorder or if they have an alcohol-induced depression. And so it's just remembering that, use kind of carefully, at lower doses and things. It's often not a problem, but it can have a depressant effect. And so for a lot of people with OCD, we know a good number of people with OCD also struggle with depression. So I'm always careful about alcohol use just in general. As far as there is no toxic relationship between alcohol and SSRIs, no concern, I'm going to take both and my brain's going to explode. That's not going to happen. What can happen is important to be aware of is SSRIs can often double or triple the effects of alcohol for some people. Not for everybody. So what I usually tell people, if they are going to drink, if someone's used to going out and having 3 drinks with dinner, what I'll tell them is when we start them on an SSRI, have 1 drink that night and see how you feel. Because you might find that you actually get the same effect that you do from 3 drinks now that you're on an SSRI and 1 drink. So it's just remembering that they can kind of increase the effects of alcohol. So when the first few times you drink on an SSRI, you want to do it really slowly because you might find you can drink half or a third as much. For some people, it doesn't affect it at all, and they drink as much as always. But again, one of the things I always tell people is when I'm trying to use medicine, especially at the beginning, and I'm trying to figure things out, I want as few X factors as I can have. And alcohol is just another X factor. And again, if somebody's having a drink, 1 or 2 drinks a week, I'm not particularly concerned. But when it gets to be more than that, again, at the beginning, I often like to keep alcohol really low or off while I'm trying to get somebody better. Because then if I get somebody better, then they can add back alcohol and they can see, does it make things worse? Does it make my life worse? But otherwise, again, it's kind of hard to know what it's doing and what it's not doing.
At 1214 from Emily. So their 9-year-old has been doing ERP for 6 months, but not making a lot of progress. Pretty unmotivated and tired from managing school all day to really work on it. The symptoms has flared a bit, and her therapist recommended it might be worth trying medication to see if it will help her better to have more energy and motivation to do the treatment. Is it good guidance? And is there a standard first-time medicine and dosage that is kind of like, normal for that age?
Sure. And so, we don't have like an age limit, right, for starting SSRIs. And it really is case dependent. And for a lot of children, again, the OCD can be really overwhelming. And they might not be able to kind of get to a place where they can kind of engage in exposure and response prevention the way we'd like them to. And so sometimes we do have to use medicine in children, and we do. And again, these are safe medicines, and including safe in children. They don't get in the way of any kind of processes of growth and development that we're aware of. And so, these are fairly safe. Again, just like with adults, the standard of care is usually high-dose SSRIs. And so, usually we will pick, there's no evidence, I think we've talked about this before on this live stream, there's no data that any SSRI works better than any other SSRI. Pardon New York City.
I know, I'm like, dude, New York's crazy.
But there's really, there's no evidence that any one works better than any other. And so, often we look, some of them have slightly different side effects than the others, or have a little bit more of this and less of this, and that's how we choose. But starting, again, a child on a low dose of an SSRI and then slowly moving it up is an acceptable treatment for children. But again, I always often, especially with kids, if I can start with ERP alone first, I do like to. And see if that alone works. If it doesn't, then I do often, we often use medication and SSRIs.
Yeah, and I'll add to it. I mean, obviously, I'm not a psychiatrist, and I know 9, sometimes parents are a little reserved. I will say that's what happened for me. It wasn't that I wasn't motivated. It's just like I kind of hit a plateau, and I know medication was what helped me get to that finish line. So I always tell people that talk to a psychiatrist, especially trust this therapist. It sounds like if the therapist is someone you trust, we'll tell you. We don't push meds because we don't prescribe it. So if we're working with a client and we're hitting like 6 months and there's just hasn't been any progress, that's when we'll strongly suggest working with a psychiatrist and asking those questions. So it sounds like, medication is safe and starting at a low dose. I think we answered most of it, but maybe quickly, Jackie asked at 12:16, is there long-term risk with SSRI like a dementia?
Does not appear to be. Again, as of now, we have no evidence to support that, again, that SSRIs cause dementia or that they're a risk factor. And again, I would say that, again, I always look at disease process and how that affects the brain. And so to me, again, if anything, again, that, SSRIs, one of the things, I tell people is we're really trying to kind of normalize brain activity, right? And in OCD, what we see is there are certain circuits that are hyperactive. And what we see is when we give SSRI medications, we can often see in imaging that those circuits actually slow down, that are usually running too quickly or are hyperactive. And so really we're trying to get your brain to function more normally, if anything. Right. But again, there's no data to support kind of a risk for dementia. I think there's some concerns recently with kind of certain anticholinergic medicine that affect the acetylcholine system. And it looks like there's a question of whether in older people, does that kind of hasten and quicken the process of dementia? And that's something that we're looking at. But SSRIs in general, again, don't have those issues.
All right, so we're at the 10 mark, so we're going to go kind of like speed round. So Jennifer at 12:44 asks, what are your thoughts on gene site testing, specifically how you'll metabolize some of the drugs you've talked about? So that's from Jennifer on YouTube at 12:44.
So, controversial topic, right? My reading of the literature currently is that there's still no good evidence that these tests are very helpful. And there are probably a lot of reasons for that. And I think that at some point these tests will be helpful. I just think they're still at their infancy. And so, as of now, I've never ordered them for a patient because there's just no data that they're that helpful. And I think part of the issue is they can look at how, certain enzymes work and how you metabolize certain things, but it's the assumption that kind of enzymes work alone. Right. And so sometimes they'll say, well, this enzyme, goes too quickly and you break down this drug too fast. But again, that, other enzymes also get involved. And so because that it's not a one enzyme system, these kind of specific and looking at one enzyme in isolation isn't always very helpful. And again, I think these tests will be helpful at some point, but as of now, the data to me does not support their use, and they can be expensive. Again, I do think at some point they will be helpful, but I just don't think we're there yet right now.
I know Barbara Van Oppen out of USC is doing a gene testing for trying to improve these tests. It slowed down because of COVID. Denia at 12:38 asks, I'm getting ERP and I'm taking citalopram, but I want to stop taking it. Should I wait?
Well, again, this is hard because I don't know your case. And again, the question is how are you doing in treatment, right? And so to me, it's, first of all, is the citalopram, so citalopram is Celexa, which is an SSRI. One question is it helping, right? Is it helping you at all? Are you benefiting from it? Are you getting any side effects from it? Right. And first of all, right, whenever you're taking a drug, that's always one of the first questions, right? Risk reward. Are you benefiting and are you getting a downside? And is the upside worth the downside? And then the question is, again, how are you doing in ERP? And so, again, if the citalopram is helping you and you are still early in ERP, I'd probably want to see somebody start to do really well. And again, I think that's also a really important reason that I think the psychiatrist always needs to talk to the therapist, right? Because they need to discuss that, right? The psychiatrist needs to know from the therapist, how are they doing in therapy? Do you think that they are at a place where they could possibly lower their medicine? And so, when I work with outside therapists, I want to know what they think. I want to know, do you think the person's ready? How are they doing in ERP? And so again, this is a tough question to answer, just given we don't really know. We don't have enough.
I like your answer earlier, and maybe Denia, if you didn't make it, it's really, he was talking about like after you're in a place where your symptoms are really managed for a year, then maybe stop taking it. At 12:35 from Padmini on YouTube, do you regularly have to be monitored, such as blood tests, if you're on SSRIs for a long term?
No, this goes, again, I think back, we kind of, it's interesting because we keep seeing these themes come up, right? Which is, are these safe long-term? And they appear to be safe long-term. And again, all the data we have kind of shows that. And so there are no blood tests that we run, again, when people are on lithium for bipolar disorder, we have to measure constantly. We measure things like their thyroid hormone because it can affect their thyroid. And we measure things like, their kidney function because it can affect the kidneys. When we use a drug called Depakote, which we also use for bipolar disorder, we have to check things like liver function because it can increase kind of liver enzymes. When we use the atypical antipsychotics, which we discussed before, we've got to kind of keep, measuring cholesterol levels and blood sugar levels because those can be affected. So it's not that we don't, do labs for people on psychiatric medicines. It's just for SSRIs, there's just no evidence that this is needed. Because it doesn't seem to impact negatively, any real systems of the body, and so we don't do any regular blood tests. There are no blood tests recommended before or while people are getting SSRI treatment.
12:22 from Howard. Does Vibryd help with OCD? VIIBRYD.
Sure. So Vibryd is also a drug called vilazodone. And vilazodone is a unique drug, right? In that it's a serotonin reuptake inhibitor combined with what's called a serotonin 1A partial agonist. And basically there's a drug that's a serotonin 1A partial agonist alone called buspirone or Buspar. And so in some ways, really kind of what vilazodone Vibryd is a combination of an SSRI and kind of Buspar. There's no reason to think that it wouldn't work for OCD, given that it's a serotonin reuptake inhibitor. I don't know that we've actually done any full studies of it for OCD, so we can't say for sure, but one would think mechanistically that at high doses, it would probably work for OCD. But again, I don't know that we've actually done a study yet to actually prove that, but one would think it would.
Julie at 12:31, is clomipramine 75 milligrams a large dose for OCD?
So again, clomipramine, also called anafranil, is a tricyclic antidepressant. Which is a serotonin reuptake inhibitor that we often use for OCD. 75 is a pretty low dose of clomipramine. The nice thing about clomipramine is we can get blood levels, so we can also get a sense of kind of how much is in the body. But 75 milligrams is not typically a dose if you're using it alone. And so you should add that, right? So when using clomipramine alone, often we're getting into the 150, 200, 225 to 50 milligram range. But sometimes we use it as an augmentation. And when we add it to an SSRI, and there's a particular interesting reaction, and we don't have time to go into it with clomipramine and Luvox, fluvoxamine. But when we use it with other SSRIs, sometimes we add a 75 milligram dose. But when we're using it alone, no, it's not a very large dose.
Austin at 12:33 says, my psychiatrist just recommended adding I-methylfolate to my regimen for OCD treatment. Do you have any thoughts on that supplement?
Sure. Okay, I'm going to just correct that. So it's L. I think that's an L.
Maybe it is the letter L. I always,
okay.
Yeah.
So L-methylfolate. And so basically, one of the things we have in our body, right, is folic acid. And one of the problems with folic acid is it doesn't have great access to the brain because it has to cross what's called a blood-brain barrier. And so they came out with a drug called L-methylfolate, and that methyl group kind of helps it get into the brain easier. And what we know is there's some data to support using L-methylfolate for some people with depression as an augmentation strategy. There's no data that I am aware of using it for OCD in any way. Again, the only data I am aware of is, again, sometimes using it as an adjunctive treatment for depression. But again, no data again. But again, it is really, we're just talking about folic acid that again, we're adding a group to allow it to kind of get into the brain a little bit easier.
Shelly at 1233 asks, I'm currently taking 80 milligrams of Prozac and 10 milligrams of Boost Bar. It's been about 10 weeks and I'm getting better, but I'm still struggling with thoughts and depression. Where would you go from here? So 10 weeks is still pretty premature, but I just want to get your
opinion. Again, right? So this is, we just, I think, always want to reiterate, right? It's hard to comment on kind of particular cases and particular patients. And so, 80 milligrams is, usually what I will tell people when I'm using Prozac, what I find is that most people with OCD are going to fall between about 60 and 100 milligrams. I would say 80 is probably the most common dose my patients are on. And then probably after that, there's a probably even split between people that need a little more and are on 100, and some people that need a little less and are on 60. And so again, usually, it depends how long you've been on 80, right? And so I don't know, when you're looking at this question, it says taking Prozac 80, it's been 10 weeks. Has it been 10 weeks since you started on Prozac? Or has it been 10 weeks now that you've been at 80 milligrams, right? And so usually I want people, let's say if I get them up to 80, I want to give them at least a month or 6 weeks at 80 to see if it's helpful or not. And if it's helpful, great. If it's not helpful, or then at that point I consider going up to 100 milligrams. Adding the buspirone here, I'm not really sure what they're trying to do. There's an interesting study with BDD that Dr. Kathy Phillipson did that showed that like certain times maybe buspar in body dysmorphic disorder, when you add it to an SSRI for people that are already responding, maybe can improve their response. But again, this is also a very low dose of buspar. And so again, I don't really know what they're trying to accomplish there. But again, 80 milligrams, again, the question really is, one of the things I always tell people, and I think this is important, is the only thing I know when you're taking 80 milligrams of Prozac is that at some point 80 milligrams enters your mouth. Right? That's the only thing I can be sure of, right? I don't know how your liver breaks it down, so I don't know how much is in your bloodstream. And since I don't really care even how much is in your bloodstream, because I have to know then how much gets into your brain. And so there are going to be people that on 100 milligrams probably have the same brain level as somebody on 40. And that's why we kind of have estimates, right? And some people are going to need more and some people are going to be less. Again, 80 is often a good dose for people, but there are plenty of people that require higher doses of Prozac. But again, you want to make sure you're giving it, a certain amount of time. And again, this is always something you should be discussing with your psychiatrist. But there are definitely people that need 100 milligrams of Prozac. I have people that, need as much as 120 milligrams of Prozac. So again, it's case dependent.
All right, we're going to get to two more, but I'm giving you 30 seconds for each of these because I know we got to go. So Alexandra at 1257, what dose does Lexapro become therapeutic for OCD?
Well, again, I think this is hard to say, right? Because everybody's going to be different, right? And we all break these things down. Typically, with a drug like Lexapro, I'm usually trying to get it up to at least 30 milligrams. And usually, it's often kind of falling, between kind of anywhere between 30 and 50 milligrams. Again, 20 is enough for some people, but I don't find that usually is effective. So usually, again, anywhere between about 30 to 50 milligrams of Lexapro.
And then lastly, Nikki at 1254 says they've been on Prozac for 25 years, does really well for their OCD, but their mood is pretty low. It's been low, especially not in summer months and since COVID, not really wanting to go out and socialize, not a lot of motivation. Is there medications that you recommend? If Prozac's doing really well for OCD, is there an adjunct medication for mood or depression that you recommend?
Well, again, I think, again, it's always hard to comment on particular cases, but also remembering, like, I have to understand there's a difference between having a depressed mood and having a major depressive episode, right? And those things really need to kind of be talked about, because there are some people that have a depressed mood, but they don't have a major depressive episode. They don't have other signs of depression. And when we're looking at medicines for depression, we're looking at medicines not for depressed mood alone. but for people that have depressed mood and other symptoms of major depression. So it's hard to know in your case, are you having a major depressive episode? Sometimes there are different drugs. A common drug we use sometimes when an SSRI is not working for depression in general, we often will add a drug called Wellbutrin or bupropion. And Wellbutrin is a dopaminergic and noradrenergic reuptake inhibitor and can often be a good adjunctive drug. But again, particular cases, I have to know, again, exact particulars. But it's one of the many drugs we add on that's commonly added to SSRIs for depression.
Yeah, for me, that was Wellbutrin. I was doing really well on Prozac for OCD, but depression was pretty bad. I went on Wellbutrin and it took care of that. Steve, we got through all the questions but two. Holly asked two really good questions more about like causation versus actual medication. So I'm going to save those because I think those were a little bit longer. We just didn't have time. So Holly, I promise we have a big sheet of questions and I put those questions at the top. So we're looking to have Steve come back maybe in June. We have a psychiatrist in May. Like we're trying to get one a month. So Steve, we're going to have you come back because as you see, there's
always my pleasure. And again, you know, it's just, this is such an important organization, the IOCDF, and really, you know, trying to make sure, again, you know, patients can't make good decisions without accurate information. And that's what Dr. Charleston trying, that's what we're all trying to do, is really make sure that you have the best information to kind of make the best decisions about your mental health care.
Yeah, no, perfect. Thank you for being here. Like I said, we had a bunch of pre-submitted we didn't get to. It seems like a lot of people were really interested in today's live stream. We had a great turnout, great questions. Like I said, Holly, my biggest anxiety is not getting to everybody, but your two questions were great. They actually were really good. I just knew there would be a little bit longer. So I'm going to save those for the next psychiatrist that comes on, make sure we get answer to those. And as you can always know, go to iocdf.org/peace of mind to see our schedule. And we put up there when the next psychiatrist and when our next lunch and learn, et cetera, is on. A big thank you to Dr. Poskar. What's the best way if they want to go to your website or contact you?
Yeah,
what's the best place
you
to
can
go?
always go to ocdnyc.com. That's my website of my office. And again, you know, we're kind of a specialized, you know, treatment center. And really what I focus on is kind of OCD and related disorders, things like OCD, body dysmorphic disorder, hoarding, illness, anxiety disorder, hypochondriasis, you know, trichotillomania and things like that. And so, you know, we do both therapy and medicine. So you can always just go to, again, ocdnyc.com and always feel free to give us a call or shoot us a message.
Yeah. Amanda put that in the chat. So make sure you go if you have any other questions, and Dr. Poskar will be back. Like I said, we're going to try to have a psychiatrist once a month to answer those questions. Come back next Wednesday, same time. We are having a special lunch and learn. The IOCDF will roll that out so you'll know what the topic will be, and we'll answer general OCD questions as well. Quickly, make sure that you go to iocdf.org/conferences. We have two big conferences coming up on May 1st. We have our virtual Faith in OCD, and then we have our 28th annual conference. Registration is open. That's in San Francisco, the second weekend of July. So make sure you come out to that. And then if you go to youtube.org/IOCDF, or if you go on Facebook under videos, this is up there. You can share it with friends or watch the beginning if you missed it. And lastly, go to iocdf.org. Just go to iocdf.org for all your information. A big shout out to Dr. Poskar for being here, and a big thank you to everyone that came and hung out with us today. Have a great rest of your day. Kick OCD's butt, and we'll see you back next week. Take care.
Yeah, everybody.